of Pediatric Surgeons. I have chosen the theme of choledochal cyst for this oration, and the emphasis is, metaphorically of course, on the roads less traveled. And I'll keep elaborating on this to tell you exactly what I mean by it. Before I actually start the oration, I have to pay my respects to the two greats on whose name this oration has been instituted. Professor Hari Shankar Asopa actually needs no introduction, at least in the field of pediatric surgery in Uttar Pradesh, in India, and even in the world. His achievements have been tremendous. He comes from an era from when things were actually quite basic, but he has achieved so many distinctions and accolades. I won't read out all of these, but to me, the most significant contribution of Dr. Asopa has been the techniques of surgery for hypospadias. And this has transformed the surgical treatment of hypospadias in many dimensions, not just in India, but across the world, to the extent that his techniques have been practiced by other people in their names as well. And some of his modifications have also been adapted across the world for people to follow. Professor Vaklu, again, is a world-renowned personality, very popular in UP and in India. He has been instrumental in setup of pediatric surgery in not only in the state of UP, but particularly in the city of Lucknow, where he has created the Department of Pediatric Surgery and nurtured it till he superannuated, and now it is one of the leading centers of pediatric surgery in India. So I doff my hat to these two greats, and I thank the UP and UK chapter of the Indian Association of Pediatric Surgeons to give me this opportunity to speak under the names. So before we actually venture out onto the roads less traveled, we need to know where we stand. And therefore, I give a very brief review of what is known about choledochal cyst. I'm sure all of you know it in this audience, but just a little recap, particularly for the postgraduates and the younger generations, so that when we talk about the roads less traveled, you will have an exact idea of what we're trying to talk. So choledochal cyst, as we all know, is a rare anomaly. Oriental races are more prone to develop. In infancy, it can be confused with biliary atresia. Females are more often affected. The lesion, why it happens, has been studied, and there are a lot of facts which are known about it, but a lot of it is still very unclear. It may be also associated with biliary atresia, and we have seen 3 cases of biliary atresia, not the classical type of biliary atresia, but atresia of the extrahepatic bile ducts and the coexistence of a choledochal cyst. Now, this is separate from the bile lakes that we very often see in biliary atresia. This is a choledochal cyst which is proximal to the atresia of the common bile duct. We all know the clinical presentation, 3 main ways in which it presents: the mass, pain, jaundice. And now, of course, we have a 4th dimension, the antenatal diagnosis. The clinical presentation, as we know, and a lot of people have now come out with their publications, we actually lost the race to Professor Roy Chaudhary. He was from India, I think, the first to mention the differences between the under 1 year people with choledochal cyst and the older children. So there are significant differences in their presentation. We know of the complications and of the effects of the choledochal cyst on the liver, on the gallbladder, on the extrahepatic bile ducts, and in the pancreas as well. I will be speaking mainly on my experience from the period of 1983 to 2018. During this period, we've seen more than 100 cases of choledochal cyst. I have categorized their presentations and their features under the category of less than 1 year and more than 1 year. And as you can see, the differences as mentioned in the literature, we have also seen the same. The choledochal cysts have been classified. There are lots of classifications available. The most commonly followed one is the modified Todani's classification, which lists 5 different types of choledochal cysts. Caroline's disease is also many a times referred to as a variant of choledochal cyst. But now there is a lot of literature available which says that possibly Caroline's disease is a disease entity by itself and it should not be confused with choledochal cyst, but that is something which is different. Now, the surgery for choledochal cyst is quite standard. We have different methods of treatment for different phases of a choledochal cyst. The most definitive treatment, of course, is excision of the choledochal cyst and drainage of the bile into the intestines. Now, whether you do it by a hepaticoduodenostomy or a hepaticojejunostomy, we heard that lovely debate in the morning, but it is a debate, and it continues as a debate, and I think it will continue as a debate for some more time till we have definite answers. My practice has always been excision of the cyst and Roux-en-Y hepaticojejunostomy, and I have never had any troubles with it, and I never felt the need or the reason to change my techniques. Complications, of course, the main complications like cholangitis, pancreatitis, portal hypertension, malignancy, these are common to most of the hepatobiliary disease states, and that are also seen in choledochal cysts. So the thing is now, what we're talking about, what we metaphorically mean by roads less traveled, is essentially that you think out of the box, you get ideas, and you try and follow those ideas. And this is exactly what I mean by the roads less traveled. So we've looked at various features of choledochal cyst, and we have tried to address some of those issues. And these are some of the things that I'm going to talk about, like what happens to the liver in choledochal cyst. If there are liver changes with a choledochal cyst, what happens to them after the choledochal cyst has been treated? Does the quality of bile differ in the choledochal cyst as compared to a normal individual or other disease states? Does the pressure inside the choledochal cyst matter? And if it matters, how does it matter? We all know that the choledochopancreatic junction has many variations, and some of them which are listed as abnormal are frequently seen with choledochal cyst. And what happens to in that situation? Portal hypertension is mentioned as part of most hepatobiliary disease states, but in choledochal cyst it is presumed. There are reports, there have been, in fact, when I talk about it, I'll talk in a little more detail about the others' experience and our experience. So we'll take these issues one by one. When we looked at all these various factors, we did a number of studies. I think there are 14 or 15 studies, and most of them have been published. And what I'm going to talk to you about is published data. So we begin with what happens to the liver in choledochal cyst. I mean, most of us, we operate on a choledochal cyst. the liver may or may not look absolutely normal. If the liver does not look normal, we generally end up taking a biopsy. Most of us would not take a biopsy if the liver looks normal. So in this study, which we did right in the beginning, when we started looking at different aspects of choledochal cyst, we took a liver biopsy. In most of these cases, we dug out the literature and we looked at the cases in which we had taken a liver biopsy. And surprisingly, even though the surface of the liver may have looked normal, we found that that the liver histologically had abnormalities. And this is what made us think as to what kind of abnormalities are there in the liver which is associated with the choledochal cyst. We looked at it in greater details, and this preliminary study told us that liver changes secondary to choledochal cyst are significant and almost universal. In the younger children, the smallest of the children, that is less than 1 year olds, these changes in the liver can actually progress to cirrhosis rather rapidly. And if a liver has cirrhosis, what does it mean? Does it mean that we have delayed the diagnosis, or does it mean that it's a severe disease in early presenters? So with this background, we looked at what happens to these liver changes in the post-operative period. So this study, again, we did over a period of time. We looked at the data in 46 patients as a prospective study. And we included children who are less than 12 years of age, but were diagnosed as choledochal cyst. We excluded children with previous surgery or who were associated with other hepatobiliary states. And the factors which we looked at were cholestasis, hepatocellular damage, parenchymal inflammation, bile duct proliferation, bile duct inflammation, central venous distension, and portal fibrosis. Now, these are standard classifications of the various changes with the respective grades, and we try to correlate our findings with these existing grading systems. The important thing to note here is that in the methodology, I mean, what pertains to for this particular talk is that we did a liver biopsy at the time of surgery, and we repeated a liver biopsy 6 months after the surgery to look at what happened to the liver 6 months after surgery. So in the preoperative liver biopsy, we found changes in all the livers. I mean, there was not one of these livers in these 46 patients which was absolutely normal. And these are some of the illustrative slides of what we saw in hepatocellular damage, in bile duct inflammation, cholestasis, which was seen as bile lakes, and portal fibrosis, which was seen as these yellow, the blue structures. So we tried to correlate these symptoms, and we found that in the children who were less than 1 year of age, hepatocellular damage and portal fibrosis were predominant. Children who had associated portal hypertension, hepatocellular damage, portal fibrosis, bile duct inflammation, and cholestasis were predominant. In children who manifested with cholangitis, cholestasis, bile duct proliferation, and bile duct inflammation were predominant. And similarly, there were predominant features with hepatomegaly, patients who presented with lump and or jaundice, and those who had an abnormal pancreaticobiliary junction. So we found that in the postoperative period, when we looked at the biopsies, we found reversal of these liver changes in a large number of patients. And as you can see, that the features in the liver which responded the maximum to operative surgery for choledochal cyst, hepatocellular damage, parenchymal inflammation, cholestasis, bile duct proliferation, portal fibrosis, and central venous distension were some of the features which showed significant improvement in the postoperative period. And therefore, what we concluded from the study was that the choledochal cyst is not just a disease of the bile duct, it is also a disease of the liver. And complications like cholangitis and portal hypertension increase the severity of liver damage. Infants with choledochal cyst have higher liver damage and merit early intervention. This was something which seemed obvious, but I mean, this is something which she proved categorically on its own merit. The pathological changes in the liver are quite similar to those which are seen in extrahepatic biliary atresia, at least in the early phases, but they differ in severity and mark the words that these are reversible after surgery, unlike biliary atresia, where most of the liver changes do not reverse even after successful Kasai procedure. So the next question was the bile which is contained in the choledochal cyst. So under normal circumstances, where the extrahepatic biliary tree is normal, the bile is produced in the liver, gets stored in the gallbladder, and is transmitted into the duodenum via the common bile duct, and that is where it acts in the process of digestion of what we eat. So this is we picked it up from the literature. This is the normal composition of bile in terms of pH, sodium, potassium, calcium, bicarbonate, and various other factors. So when we look at the bile, which was taken from the choledochal cyst itself, not from the gallbladder, but from the choledochal cyst, we found that there were definite changes as compared to what the normal bile is, and therefore these abnormalities, we were actually at a loss to explain as to how these abnormalities can be explained. But when we look at the various factors, and then we also tried to correlate the abnormalities in bile with whether the intrahepatic bile ducts were dilated or not dilated, we found that the pH, amylase, lipase, calcium, these were significantly different as compared to normal bile, although other factors were also abnormal in comparison to the normal constituents of bile. And the only thing which we could understand from this was that we did not look at it, but from what we can understand is that there is a backflow of pancreatic fluid into the extrahepatic biliary ductal system, and some of these aspects of the bile composition can be explained on that. For example, normal bile would not have any amylase or lipase. So if you're finding amylase and lipase in the bile from the choledochal cyst, it means that the pancreatic juice is going across into the choledochal cyst via an abnormal pancreatico-biliary junction. This may have its own implications, and I guess, and I would like some of the younger people in this audience to take up these issues further and look at the various correlations which can be drawn from it. Now, it is a common observation when you are operating on a choledochal cyst. When you open the abdomen, you find it in different sizes. When you touch it, feel it, you find some of them are tense, some of them are not so tense. So obviously these things express the intrahepatic pressures within the choledochal cyst. Now, what does that imply? So we did this study and we measured the pressure inside the choledochal cyst by putting a wide bore needle, making sure that there is no spillage of bile across. We connected it to a pressure transducer and we measured the intracholedochal cyst pressure in millimeters of mercury, and we found that almost all the choledochal cysts had changes of pressure. And therefore we tried to see what it would mean. So when you look at some of the choledochal cysts, the pressure inside was very high. Some of them did not have a very high pressure. So we arbitrarily divided them into low pressure and high pressure systems. And we found that larger cysts tend to have lower intracholedochal cyst pressure. Long common channels tended to have a higher intracystic pressures. And abnormalities of the wall of the cyst was associated with lower intrahepatic pressures, intracystic pressures. When we looked at these pressures and tried to correlate it with the bile composition, we found that in situations where the bile had more lipase or amylase, these are the situations where the cyst pressure was high. So what we concluded from this study is that whether the intracystic pressure has an effect on the various nearby structures, or whether it is a reflection of the quality of bile or a reflection on the status of the wall of the cyst. Difficult to say at this moment, but I guess, again, more work would illustrate it further. The important issue here is that high pressure systems were smaller in size. There were more severe back pressure changes. And this could again be because of the high pressure inside the system, the back pressure changes. But the low pressure cysts were larger in size. Possibly the wall was more pliable and therefore the size was bigger, and the bigger size dissipated the intracystic pressures. There were higher levels of amylase and lipase in these cysts, and there were more severe changes in the cyst wall, which again could mean that these kind of cyst walls were more akin to something like what we see in an adynamic bladder, which is large but has a lower pressure inside. Now, the choledochal pancreatic junction, I mean, it's been a topic of discussion for years now, for decades now. And everyone talks about an abnormality of the pancreatico-biliary junction in association with the choledochal cyst. So when you look at the abnormalities of the pancreatico-biliary junction, you find that they are described into three kinds, which is normal, less than 1 centimeter, more than 1 centimeter. And there are various ways in which people have classified the abnormal junctions. We did the study. Unfortunately, we did not publish it. But in the beginning, we used to do an operative cholangiogram before the MRI became available. And we used to do the operative cholangiogram through the gallbladder, and we used to document the pancreatico-biliary junction. But after that, once the MRI became available, we used the MRI to focus on the pancreatico-biliary junction, and we could get almost identically accurate results as compared to the operative cholangiogram. So we found that if there was an abnormal pancreatico-biliary junction, there was a strong correlation with severe grades of all parenchymal injury parameters, which basically meant hepatobiliary damage, parenchymal inflammation, and portal fibrosis, but not with any bile duct parameters like the bile duct inflammation and proliferation. Those without any abnormalities had significantly more cholestasis, indicating that the mechanism of liver injury with the abnormalities of the junction is not because of bile flow obstruction, but because of other factors. And the children with abnormality in the bile duct junction and the choledochal cyst, they demonstrate greater liver injury, even more than ductular injury, and thus require aggressive and early treatment of the choledochal cyst to prevent irreversible liver injury and fibrosis. And that is why I think the time has now come that we should focus on the pancreatico-biliary junction as well, and try and evaluate it before we set out to operate the choledochal cyst itself. So, portal hypertension. Now again, portal hypertension is something which has been discussed very often in association with hepatobiliary disease states. We also studied it in choledochal cyst, and the impetus actually came from a paper which was published in PGI Chandigarh, and they made a correlation between portal hypertension and choledochal cyst. We carried that something of that kind of a study a little further. We used more objective parameters, And this is what we did. So in 20 patients, we recorded the portal pressures by measuring through a transducer, a pressure transducer, by cannulating one of the omental veins. But we realized that we will not be able to measure the portal pressure in the post-operative period. So we also did blood levels of nitric oxide, and we have done a lot of work on blood levels of nitric oxide in various hepatobiliary states. Most of it is published. And we found that the changes in portal pressure are closely followed and almost identically followed by blood levels of the nitric oxide. And therefore, the blood levels of nitric oxide are a very accurate reflection of the portal pressures. And so in this study, in the post-operative period, we used the nitric oxide blood levels to compare it with the pre-operative nitric oxide blood levels as a reflection of portal pressure. So again here, because we did not have any set criteria, we arbitrarily divided portal pressure into less than 14 millimeters of mercury versus more than 14 millimeters of mercury, and we tried to correlate it with several things, and the histological liver parameters were one of them. The only thing which correlated well with this was the bile duct proliferation, but the rest of it, the portal pressures did not have any effect on the portal hypertension. Similarly, when we looked at the nitric oxide blood levels, we found again that bile duct proliferation was the only thing which had a significant correlation, and therefore we were quite satisfied that the nitric oxide blood levels and the portal pressures have a good correlation. So when we looked at the portal pressures, preoperatively, blood pressure, portal pressures, or the nitric oxide levels, whichever you may choose, there is a significant difference between the preoperative and the postoperative portal pressures. Similarly, for the blood levels of nitric oxide, there was a significant correlation between the preoperative and the postoperative parameters, and we saw that there was a significant drop in the portal hypertension in the postoperative period. So a lack of correlation with histological features and a significant drop in the portal pressures postoperatively tells us something which is very important. It tells us that despite liver changes, the portal pressures are high not because of the changes in the liver histology, but there are other factors which increase the portal pressures. Could possibly be the pressure from the choledochal cyst itself on the portal vein, which lead to higher portal pressures. And once the choledochal cyst has been removed, the portal pressures tend to reverse and become almost normal. So this was a very important feature, and I think in the overall prognosis of children treated with choledochal cyst can have a good bearing. So this is where I end. And like I said, when I talked about the roads less traveled, so if you are here, this is where you stand, and you take a road and you continue doing whatever you've been doing, or you take another road, think out of the box, look at aspects which have not been studied, and see that the implications of those factors with the overall prognosis of biliary atresia. This is something which will enlighten you, and possibly in the days to come, this little darkness which you see under the lamp, you'll be able to illuminate that further. I show this picture of folded hands for two reasons. One is to thank all of you for listening to me patiently, and also as a request to future generations of pediatric surgeons to continue working on the unknown, the untraveled roads and factors which have not been studied. So you actually have to sit calmly, spend a few minutes with yourself, ask yourselves questions. The more questions you ask yourself, the more ideas you'll get to study, and the more knowledge you'll be able to spread and enlighten yourself and the others. Thank you very much.